Good evening, everyone. I hope you are well and safe wherever you may be. On behalf of Alpha Phi Alpha's General President, Brother Dr. Willis Lanza III, I am Brother Dr. Jeffrey Sterling, the Surgeon General for the Alpha Phi Alpha Fraternity Incorporated. This evening, I am just very pleased to have this group of brothers presenting on oral cancer. It is a topic that is topical, it is something that is relevant to you, and something that is eminently preventable. So, as you listen to the talk this evening, I want you to listen to it with a mind for how you can be empowered to avoid this deadly disease. And believe it or not, this is something that you might want to share with your loved ones because there are treatments and preventative efforts that are within your reach that can make this a part of the distant past if we engage and employ them correctly. Our moderator for this evening is our Deputy Surgeon General for Dental Health, Brother Dr. Langston Smith. Brother Dr. Smith received his DMD degree from the University of Kentucky in 1977, after which he joined the U.S. Navy and served for 30 years on active duty. He completed his Navy fellowship in endodontics at the Naval Dental Center in San Diego, California in 1983, and a residency in endodontics at the Navy Postgraduate Dental School in Bethesda, Maryland. Brother Dr. Smith is a diplomat of the American Board of Endodontics, receiving that certification in 1992. Following his retirement from the Navy, Brother Dr. Smith served as associate professor and chair of the endodontics department of Howard University College of Dentistry for 12 years before retiring in 2019. Brother Dr. Smith's military awards include the Legion of Merit, the Defense Meritorious Services Medal, the Navy Meritorious Medal, the Navy Commendation Medal, the Global War on Terrorism Medal, the Humanitarian Medal, the National Defense Medal, and the Sea Service Deployment Ribbon. He has been Alpha Man of the Year in 4 chapters and the Eastern Region Alpha Man of Merit. Did I miss anything, Brother Dr. Smith? You're a phenomenal brother. We are so pleased to have you with us. Have a fantastic show, and let's empower our brothers and our audience.
Thank you, Brother Sterling, for that outstanding introduction. I appreciate that tremendously. So, to our audience, good evening, and welcome to this edition of the Alpha Phi Alpha Fraternity Surgeon General Initiatives webinar. As Dr. Sterling mentioned, I am Langston Smith, Deputy Surgeon General for Dental Health, Alpha Phi Alpha Fraternity Incorporated, and I welcome you tonight on behalf of our General President, Brother Willis L. Lanza III, our Board of Directors, and of course our Surgeon General, Brother Dr. Jeffrey Sterling, and our team of Deputy Surgeons General. It is good to have you with us tonight as we continue our efforts to keep you better informed of health issues that we face. Tonight, our discussion is on oral cancer. Oral cancer is one of those issues or one of those conditions that we don't hear a lot about as some of the other cancers. So I will lead the discussion tonight on just what is oral cancer. My discussion will be followed by a discussion on the diagnosis and treatment planning of oral cancer by Drs. Tom Edler and Dr. Dana Jackson. Then Dr. Jackson will go into the treatment and management of oral cancer cases, and Dr. Edler will close it out with a discussion on restorative and prosthodontic treatment modalities for the management of oral cancer. Following the discussion, we will have a short question and answer time after the presentations, and we ask that if you have any questions that you would like for our panelists to answer, please put them in the comment section on the screen, and we will try to get to them at the end of our presentation. Our panelists tonight, an esteemed group of professionals, Dr. Thomas Edler. Dr. Edler received his dental degree from Howard University College of Dentistry, Washington, D.C. He completed a general practice residency at the University of Medicine and Dentistry of New Jersey, and his residency in prosthodontics and oral biology at the University of Maryland. He then received his certificate of maxillofacial prosthodontics and dental oncology at the University of Texas MD Anderson Center in Houston, Texas. Dr. Edler has been an assistant professor of prosthodontics at Howard University and is currently staff prosthodontist, the Veterans Administration Medical Center, Washington, D.C. Welcome, Dr. Edler. Dr. Dana Jackson. Dr. Jackson is chair and program director of oral and maxillofacial surgery at Howard University and College Hospital and College of Dentistry. He is a diplomate of the American Board of Oral and Maxillofacial Surgery and a fellow of the American Association of Oral and Maxillofacial Surgeons. He also serves as associate professor at Howard University College of Dentistry with over 20 years of service. He has held several positions of leadership on the local and national level and has lectured extensively on his specialty. Welcome, Dr. Jackson.
Thank you. My pleasure.
Tonight, slide 1, please. Tonight, I would like to initiate this discussion on a topic that does not get the level of public awareness as some other cancers. You may go to slide 2. Oral cancer is one of the least common cancers in the United States. Oral cancer accounts for 3% of all cancers diagnosed each year. Data reports that oral cancer will be responsible, and this is data from the American Cancer Society, that there will be over 12,000 deaths in 2024, which leads us to the why of this discussion tonight. Now, just to kind of bring it into focus, there are some notables that have succumbed to oral cancer. The most one I know best is Tony Gwynn, the Hall of Famer baseball player that played so long with the San Diego Padres. And then Eddie Van Halen, and then Jim Kelly with the Buffalo Bills. And if we go back some years, Babe Ruth. So this is a condition that has been around, but we just don't hear much about it, yet it can be very, very destructive. So these are some graphics of oral cancer. If we look here, we see oral cancer in the palate, and over here on the gums, okay? Next slide, please. So as I said earlier, the American Cancer Society estimates that there will be 58,450 cases, new cases in 2024, and of these, about 12,230 deaths will occur. Now, one of the things about oral cancer is that it is more common in men than women. And it has a higher incidence in Caucasians than African Americans. Oral cancer is more prevalent in older people, with 63 being the average age of occurrence. However, there's a 20% incidence rate in people under 55, usually around the age of 40. Okay, so our next slide. So what is oral cancer? Sometimes it's referred to as oropharyngeal cancer because it occurs in the mouth through the middle of the throat, and therefore it's in that pharyngeal region. That is why we recall it as oral cancer. Some folks even refer to it as one of the head and neck cancers. So it's a cancer that starts in the mouth or throat, and 90% of these cancers are squamous cell carcinomas. Now you say squamous cell carcinomas. What are squamous cells? Squamous cells are those thin, flat cells that we find in tissues lining organs. We find in the skin tissue, okay? And they line these hollow organs, and they form the lining of the respiratory tract and the digestive tract. So it is the cancer of these cells that we are talking about. And so if we look at it, we find this cancer occurring in the cheeks, the lips, the gums, the floor of the mouth, the roof of the palate, the tongue, the jaws, and down the mid part of the throat, okay? Right, next slide. So, some of the facts here. We've already established the fact that oral cancer occurs in older populations mostly, more commonly in men and women, all right? And it's highest in smokers and alcohol abusers. Now, it doesn't matter the tobacco, and we'll get into that a little bit later, but tobacco users, alcohol abusers, and it occurs in those with a high exposure to sun and who work outdoors quite a bit and don't protect their lips. Now you say, there is the death rate is high. So why is this death rate high? Well, number one, oral cancer is hard to diagnose. Well, why is it hard to diagnose? It's hard to diagnose because it goes for so long being unnoticed. Number one, it's generally painless. Okay. And this is one of the dangers, in that it is not detected in its early stages. All right. And there are very few physical characteristics that occurs that you can pay attention to in the early stages. Okay. It's not hard to diagnose, but it is discovered late. And so therefore it's difficult to find it out. The lifetime risk of developing oral cancer or oral pharyngeal cancer is 1 in 59 for men and 1 in 139 for women. Mainly, we said earlier that it's more prevalent in men. There's a 57% survival rate. All right, that survival rate could be higher if it was detected earlier. There's recently, especially since the mid 2000s, the incidence of oral cancer has increased by 1% per year due to the rise in HPV infections. And we'll find that HPV infections now may be one of the leading causes of oral cancer, and we're finding it in younger populations. Right? Next slide. So, what are the risk factors of oral cancer? We mentioned smoking and alcohol. Smoking abusers, and it's not any particular type of tobacco. And I said smoking, but it's really tobacco. So that is smoking, cigars, cigarettes, pipes, chewing tobacco, snuff. And there is a recent occurrence where we are generating to, cigar smoking, which is a common thing now, which is the thing. All right. So when we talk about cigar smoking and the tobacco of cigars, we know that that's going to have some effect on the oral cancer and the pharyngeal area that affects it. So there's this big tendency for smokers to develop oral cancer. Now, alcohol abusers, not for those individuals that drink here or there, a little bit, but the alcohol abuser. But what research has shown from the American Cancer Society is that when smoking and alcohol abusers come together, it acts synergistically. And so this synergistic action between tobacco and alcohol leads to a higher incidence for oral cancer. Okay. Then sunlight. And you can see the pictures here of the sun sores, the sores and the blisters from those individuals who spend a lot of time, which leads you to a higher incidence of oral cancer. And this is unprotected. So those individuals who spend a lot of time outdoors working or playing, they should protect the lips in order to prevent the incidence of oral cancer. And we've talked about the HPV virus, okay? And all the ways that HPV viruses are transmitted. Yes, there's higher incidence when it comes there. And it is definitely a risk factor for oral cancer. A weakened immune system, okay, predisposes an individual to oral cancer. And for that reason, any cancers, but definitely for oral cancer. And it does occur more in older populations. Now, whether that's related to the weakened immune system or just aging, we haven't put the finger on that or not, but we do know that it does occur in older populations, okay? Now, I want to go back and mention here with the HPV virus. Now, this incidence has been found in individuals who don't smoke or don't drink alcohol, but yet because it is there and that virus is there, we find that is one of the causes, okay? All right, next slide, please. So you say, okay, doc, how do I know? What do I look for if I'm concerned about oral cancer? Well, these are some things that you may want to look for. Red and white patches that last for 10 days or more. So if you develop these red patches on the palate or the tongue, and they're there for 10 days or more and don't go away, all right, that's a cause of concern. So if you say, okay, well, it's been there for 10 days, what do I do? go to your dentist and have them check it out, have them do an assessment. If you have sores, ulcerations that don't heal, and here again, the tissues of the oral cavities is the fastest healing tissue in the body. So when it doesn't heal over these 10 days, that tells you something that you need to get it checked out. If you experience numbness of the tongue, any numbness, if you feel a lump of thickness in the soft tissues in the throat, the palate, the jaw, and it doesn't go away, get it checked out. If you feel like something is caught in your throat, or if you're hoarse for a period of time and it doesn't get away, get it checked out. Now, sometimes we develop unexplained mouth pain. And when this mouth pain doesn't go away, get it checked out. So when these signs and when these symptoms develop, it may be nothing, but then who knows? It may be something that needs to go for an absolute diagnosis. Okay. So these things develop. Let's go to your dentist and get them checked out, because the dentist is going to be the first order of defense or treatment that you will experience or should experience. Okay. All right. Next slide, please. Now, we talked about the signs. Let's look at these. The white patches. We normally refer to this as a leukoplakia. All right. And the red ones as a erythroplakia. Okay. These are seen here right on the side of the tongue. These are seen here on the palate. And so if these are noted, all right, if they persist for more than 10 days, they should be evaluated by your dentist. Now, just because you have leukoplakia or erythroplakia, you don't go saying, I got oral cancer, I got oral cancer. Could be the furthest thing from the truth. These things occur for any number of reasons. So, but if it stays there and it stays there over a period of time and it's not treated, it could develop into oral cancer. Okay, next slide. All right, now, what does oral cancer look like? Let's look at this slide of the tongue. Right here. Now, you see how indurated this is? You see how ulcerated this is on this side of the tongue? These are cancers. All right. These are cancers. All right. Next slide. Oral cancer of the palate. We showed this slide earlier, but I bring it back to show these are white patches. It hasn't gone away. And you can see some induration or ulceration right here. All righty. Next slide. All right. And here we look, you would automatically think this might be sunburn. It may be a fever blister. But look at how indurated it is. Okay. Look at the rough edges around it. And if you go here behind this molar and you see this ulceration back here, these are cancers of the lip and the jaw. And next slide. Okay, so you say, I've got these situations on my tongue, on my lip, and should I get them checked out? Yes, but here are some non-cancerous entities that you might experience. Take the cold sore. And here's what we call a traumatic ulcer, because you can see this patient has been abrading this tooth or this filling against the cheek. And here's an aspirin burn. This person had a complaint of pain in this area. And what did they do? They put an aspirin there to relieve the pain. Well, the best thing to do when you take an aspirin, when you use aspirin for pain relief, is to swallow the aspirin and not put it on the gums, because you're going to get an aspirin burn. Okay, so there are non-cancerous entities that you should be aware of. But if you're really concerned about it, you really don't know, take it to your dentist and get it checked out. Okay. You can also get issues, situations that develop when you burn your tongue with pizza. All right. Next slide. So how do you prevent? Always inspect the oral cavity and look for changes. Make sure your dentist does an oral cancer screen during your annual exam. Prevention is the key to early detection. Don't delay treatment. The aggressive treatment is surgery, radiation, chemotherapy. Doctors Edler and Jackson will get into this a little bit later. All right, next slide. So the oral cancer screening, what your dentist is going to do, he's going to do a visual inspection. He will do a physical evaluation. He might even use light, radiographs, or x-rays, or may even consider a biopsy. Next slide. So once it develops, the treatment protocol, it is a multidisciplinary treatment. Oncologists, surgeons, nutritionists, oral surgeons, and dentists form a team. There's radiation therapy, which destroys the targeted tissue. There's surgery, chemotherapy, and chemotherapy. Okay, next slide. And with that, what I've tried to give you here is some introductory information to oral cancer. Now I will turn it over to Dr. Jackson to discuss diagnosis and treatment planning of oral cancer. Dr. Jackson.
Yeah, thank you, Dr. Smith. I'm chairman of oral and maxillofacial surgery at Howard University in Washington, D.C., and Washington, D.C. is known to be number one in a number of unfortunately, a number of disorders, including oral cancer. So we see a number of patients that have this, and so our team is trained to do good, thorough examinations of each and every patient as they come through the door, because it's important that we diagnose early. If we diagnose early, then you have the opportunity to treat before it becomes too debilitating. So the oral and maxillofacial surgery, as well as general dentistry, as well as process, all the specialties of dentistry, as Dr. Smith said, are the first ones to see it, the first ones to evaluate it and refer it. So if you do your every 6 months visit to have your teeth cleaned and you have a good oral examination, then you're ahead of the curve. And that's what we're trying to get to you. To come in early, let us look at it, because we can notice things that may or may not appear normal and refer them to the appropriate persons to evaluate. Next slide, please. So, as Dr. Smith was, there are some things that just give you an idea. Now, none of these are specific, but they can give you an idea whether or not the patient has something out of the ordinary. When you're coughing persistently, that means that something's irritating your throat. Now, is it irritation because of an infection or mucus or some kind of irritation because of something you ate? Potentially, but if it could persist, like 10 days or more, and it doesn't go away, and you can't put a reason behind it, then that's something to be concerned about. When your voice changes, that means your vocal cords have been involved. Your vocal cords allow you to speak and talk and give you your resonance to your voice. When you start to become hoarse or the sound changes when you speak, that's something that needs to be looked at. When you swallow and when you breathe, of course, that goes from the mouth down to the lungs, as well as to the nasopharynx. You have to be cognizant of what is normal, what's abnormal. Pain on swallowing is not something you normally see. So when you have that difficulty swallowing, then find out what the reason is behind it. As far as ear pain, anything that involves the jaw can involve the nerves that supply the jaw, which includes the nerves, the trigeminal nerve, which is the main nerve supply to the head and neck, that also supplies the ear, which can have ear pain. You can have tinnitus. You can have a lot of different disorders that mimic an ear disorder that can be related to something going on in the mouth. Any lumps or sores you have in the throat that are persistent, that don't heal, that is a concern and needs to be looked at. It could be related to trauma, could be related to something that you ate that didn't settle with your stomach or your mouth, but you don't know until it's evaluated. So when we see lesions in the mouth, we all automatically note them, and then if indicated, we send them for further evaluation to determine whether or not they're normal or whether or not they're pathologic. Once again, the sore throat, and then we have weight loss, not a normal finding. When you have rapid weight loss, that means there's something that's eating, your metabolism is heightened, and something is eating away at your tissues and causing you to lose weight at a very high level. And that could be related to a malignancy such as cancer, or could be related to an autoimmune disorder such as AIDS or HIV, but it needs to be looked at to further evaluate. Next slide, please. So when you look at head and neck cancers and sores, we look at three different areas. We look at the nasal pharynx, the oral pharynx, and the hypopharynx. The nasal pharynx is the nose. The oropharynx is the oral cavity, and hypopharynx is the larynx, and where you have your, where your speech and your hoarseness and is associated with it. The oropharynx is what we see the most commonly because we're dentists first, and we look at those areas because we often see cancer develop in certain areas of the mouth. The lateral border of the tongue is the primary area that we see where you have a white patch that's there, but it can occur in other areas of the mouth, in the vestibule or back in the palate. Whenever you see something that looks abnormal, it's incumbent upon you as a professional and as a patient. We encourage our patients to look in their mouth. If they see something that doesn't look normal, doesn't look pink like your other tissues look, or it looks like something is sticking out or something that hurts that shouldn't be there, then have it checked out, because that's the best way to have somebody that knows to look at it so they can kind of give you the assistance that you need. Next slide, please. The good thing about diagnosis of oral pathology is that it's gotten better. Over the years, we have diagnostic aids that have improved that allow us to better evaluate and diagnose those things that are abnormal. And we have utilized a number of these things in our practice that make diagnosis of pathology a little bit easier. Now, some of these things are just give you an idea, and you have to do the official biopsy to see, but it does give you an indication that something is not quite what it should be, and it's worthy of further exploration to determine exactly what it is. Next slide, please. So, as Dr. Smith has said, oral cancer has a lot of different appearances. It can appear white, it can appear red, it can appear bleeding. You may not even notice it because it doesn't always become painful until later on. But it can occur in the soft tissue, can occur in the bone. And once it begins, because cancer cells always grow faster and divide a lot faster than normal cells. So it begins to spread very quickly, and it can involve start at the tongue, and then it can spread to the lymph nodes, or into the throat, or into the lungs. When you say that the term metastasis, that's where the cancer starts in one area and it spreads to another area of the body. Once that occurs, then your prognosis goes down, because the cancer that starts in the mouth and gets into the lungs and gets to other areas of the body is much more difficult to treat. It's much easier to treat at the site. So the earlier you are able to see it and treat it, then you can stop it from spreading. Because once it spreads, then you have to include other different modalities of management, and you take surgery out of it, and you have to get radiation and chemotherapy and other things that of themselves they can be beneficial, but they also are very, 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 very toxic to the body as a whole. So it hurts the body to have to take these medications to try to control the cancer. The hope is that the cancer cells will be killed and your normal cells will survive. But it really takes its toll. If you've had anybody that's ever had chemotherapy, and they lose their hair, they lose weight, and the attempt is to control the cancer, and hopefully the cancer cells go away and they can return to normal. But you want to try to get it before it begins to spread. So that's what our objective is for you today. Next slide, please. So one of the things that has become, and we use in our office, the Biloscope, and what it is, it's a light that with a camera on it, and it shows a certain type of ultraviolet presentation that causes certain tissues to appear in a certain color, and it will identify where you have discrepancies in the normal architecture outline of the soft tissues. When you see things like this, it indicates that there's something going on that's not normal. If you look in the lower right slide, the green, you see that circular area where you have an area where it appears dark, where everything else on the palette appears green, light green. That's an area that it needs to be investigated. It's not 100% sure there's cancer, but it gives you an idea that something needs to be biopsied. So we have our dental hygienists who are not doctors that will see this, and they will refer it over to the doctors to a further evaluation to determine if this is something that's normal or abnormal, whether it needs to be biopsied or seen by an oral surgeon or other specialty to determine exactly what's going on. Next slide. We also have different chemicals that we can use. Toluidine blue is a chemical material, a blue stain that can be put on the tissues that is absorbed differently in cancer tissues than it is in natural tissues. And so when you get the blue that's being absorbed differently, then that gives you an idea whether or not that you have normal absorption versus abnormal absorption, and it can indicate whether or not you have something that may need to be looked at further. Next slide. A brush biopsy is when you have an area where, if you look at the white patch that's on the soft tissue of the tongue and the soft and hard and soft palate, this tissue has a white patch that's not normal. You normally talk about coral pink and pink gingiva that appears normal. We have a white patch. That is something that you need to look at, because white patch means there's something going on to give it that color, and it may be chronic irritation or maybe a transformation of the mucosal tissues. But you can take a brush biopsy and just scrape it with this little brush you see over here on the right side, and you can take some of those cells and have them evaluated. Cancer cells have a different appearance than normal cells. So as you brush it and you're able to look at it under the microscope, you can determine whether or not you have some cells that are abnormal or growing abnormal that may indicate a transformation from normal to malignant cells. Next slide, please. So in terms of diagnosis, we have a lot of radiographs and other diagnostic studies that we can utilize. Being dentists, the most common X-ray we take in office is a Panorex. A Panorex gives you a view of the entire jaw and the teeth. It shows you the sinuses. It shows you the mandible. It shows you where the nerve runs or where your teeth are, and it kind of gives you an overview of the jaw. And it's a good screening tool for not only a dental problem like cavities and lost teeth and other oral issues, but also if you have cancer that's invaded the bone, you can see areas where it may erode the bone and eat away at the bone, and that can kind of help you with your treatment planning. Next slide, please. The CT scan, the CAT scan also is if you go to a hospital, this is probably the most common study that's done. CT scans give you good evaluation of both the hard and soft tissues of anywhere in the body, and it gives you a three-dimensional view where you can see height, width, and length, and it kind of gives you an idea of what's normal, what's abnormal, and helps to plan your treatment. And it's a very, very, very good study that's been used for years in the hospital, and it's something that helps us to plan treatment as well as diagnose what's going on. Next slide, please. The MRI, once again, is also a good study that's done. It's different. It doesn't include radiation with MRI, where the CT scan is radiation. This uses magnetic resonance, and it gives you sounds that are absorbed, that give you different kinds of contrast to the soft tissues. This is good for soft tissue evaluations, and it can also help to diagnose certain types of pathology, including benign and malignant pathology. Next slide, please. Now, the PET scan has come about in the last 10 or 15 years because it is the type of a CT scan, but it's specific for evaluation of metastasis, where lesions spread from the primary and they spread throughout the body. So when you take a PET scan, that allows you to evaluate where the cancer started in the mouth, and you can see where it highlights areas in the lung or in the abdomen, in the stomach or the liver, where it has metastasized. So part of the cancer evaluation process involves a PET scan, because when the cancer starts, is not where it ends. But when it does spread outside of the oral cavity for oral cancer, then it's problematic and involves multiple ways to try to manage. And the PET scan is the diagnostic tool of choice when you're evaluating the patient for spread from the primary site to other areas of the body. Next slide, please. So the best way to diagnose cancers is to take what's called a biopsy. A biopsy is a sample of tissue that's taken from the site where you see something that looks abnormal. There are two types, basically. If the lesion is small and you're able to remove the entire lesion, It's called an excisional biopsy. I mean, you size the whole thing, and then you submit that for evaluation and determine exactly what the pathology is. If it's a large lesion, you can't take the whole thing because it's too large, and then you have too many vital structures like nerves and blood vessels and other structures in the area that may not be amenable to that type of procedure at the time. An incisional biopsy is taking a smaller piece of the larger lesion to determine what it is. Then once you determine what it is, then you can determine what the treatment is going to be. You have to know what the treatment is going to be, so you have to know what it is, because there are some surgeries that involve conservative therapy. Some are very aggressive, where you take out portions of the jawbone and soft tissues. So you have to have a biopsy to determine what it is, and you have to have a guide for whether or not it's in a very aggressive cancer or it's a benign type of tumor. It's not cancer. They are managed differently, so their biopsy will give you exactly what you have to determine to plan your treatment. Next slide, please. Once again, the incisional biopsy allows complete removal of the lesion, and you always try to include some normal tissue so you can compare what's normal, what's abnormal, and the pathologist gives you a report, and the report is a written report that gives you exactly what the diagnosis is and tells you what it is, and then from there you can get how aggressive it is, and determine what your surgery is going to be in terms of removal. Sometimes you have to take normal margins that are above and beyond the actual tumor itself, because it's a very aggressive tumor. Sometimes you're just able to excise it at the margin of the lesion without taking any normal tissue. But until you get the biopsy and evaluate it under the microscope, you don't know what you have. Next slide, please. So when you send the biopsy in, you get what's called a pathological diagnosis. It's sent to a lab, and they look at it under a microscope, and they tell you exactly what it is. Now, this is a biopsy of squamous cell carcinoma. And not to say that we want you all to be able to recognize this, but once we see this, we know that it is a malignant lesion that needs to be managed in a particular way, where you need to have 1.5 centimeter margins beyond it. And you don't just try to just the area of where you see the tumor, but you have to take some normal tissue to make sure that you don't leave any tissue or tumor there, because you get what's called recurrence. Recurrence is when you try to remove the lesion and then it comes back. And so you want to try to minimize recurrences, because recurrences require additional surgery, and you want to try to get it out so that you can have a curative measure for the patient, but you're not always able to do that. But the diagnosis of what it is allows you to determine what your margins are, determine how aggressive your surgery is going to be in terms of management and treatment. Next slide, please. Once you get the diagnosis, there is a standard way of categorizing and staging tumors of the jaw. The TNM staging classification, which means tumor, lymph nodes, and metastasis. Tumor is the size of the tumor. How big is the lesion? The lymph nodes, has it migrated to the local lymph nodes, which are normally under the jaw, and then metastasis means it's spread away from the primary site to other areas of the body. The higher the TNM number, that means the more aggressive the tumor is, and the more aggressive you have to be in terms of your treatment. This also allows you to determine whether or not you're going to use chemotherapy, radiation therapy, or a combination of the two, as well as surgery, to remove the lesion. So every institute has a tumor board, which they will categorize the tumor in one of these stages. That will give a number, a TNM number, and this is standardized across the country, so that you can determine what it is and determine what the appropriate ways to manage it. And because it's not all one way, it's not all surgery, it's not all chemotherapy, it's not all radiation. There are other things that can be done currently that can help you manage the tumor. Next slide, please. So surgery is one way, radiation therapy, chemotherapy. You can use targeted therapy, where you use chemical mediators that will specifically attack that particular lesion to kill it, and just that, and nothing else around it. And then you can use immunotherapy, which you use your white blood cells and your immune cells to help to fight the infection. And once again, the TNM classification will allow you to look at that, apply the appropriate methods of treatment, and to try. The whole objective is to make sure the cancer goes away and doesn't come back. So we've evolved over the years, and we're getting better and better and better at fighting cancer, which is very positive. But it's not an exact science, but you have to get the background information in terms of diagnosis, and then you can work at a combination of medication of modality of treatment to help to manage the actual tumor itself. Next slide, please. Chemotherapy, we're familiar with that, where you usually 8 to 12 or 16 weeks of IV fluids that are given to help to fight the cancer. Once again, this is a way to fight the cancer, but it's also very debilitating because you not only kill the cancer cells, but you knock down your normal cells. Most patients on chemotherapy, as you know, you'll see with loss of weight, they'll lose their hair while they're on the chemotherapy. And the intent is to control the cancer so it does not continue to spread. But it is effective in combination with other modalities, depending on what the diagnosis of the cancer is. But it is something that's going to take you down. It's going to make you lose weight, and it makes you more susceptible to infection and other things associated with that. So you hope to survive the chemotherapy to get the cancer out of your system. And then once you're done with it, you'll start to get your weight back and you start to return to normal. Next slide, please. Radiation therapy is evolved over the years, and it is better now than it was. Now, remember, radiation is something that you can use to kill the cancer tumor, but it's cumulative, which means that once you give radiation, it doesn't go away. So if you give a certain amount in year 1, 2, 3, 4, 5, 6 of your life, it's additive. At a certain point in time, the radiation becomes to a point where it starts to kill off your blood supply in the bone of the jaw. So you want to try to monitor the amount of radiation, and then with high dose radiation, that's a new way that's done, where it passes through some superficial tissues and goes to the deeper tissues, so you don't have the total accumulated dose that you would normally have. So these techniques are available in many cancer centers around the country, and they make the radiation a little better than it used to be. But radiation itself, it does have a negative consequences. We get too much of it, so you always want to monitor it to make sure that that you're not hurting the person more than helping them. But it is a way to fight certain types of cancer, and it can be very effective in helping the patient to live a normal life. Next slide, please. Immunotherapy, as we talked about, is using your immune cells, and what you do is train them a certain way, and then you inject the immune cells, like your T cells and lymphocytes, to become attack cells that attack the cancer and help to remove it or eliminate it or reduce it. And this has been some of the new therapy that's out there that can help patients that have cancer to survive a much longer time. Next slide, please. And the same thing with targeted therapy, which you certain types of drugs and that target the exact cancer itself, and they're not specific to anything else other than that cancer that you have, and they can be used to inject into the site and actually help to eradicate or reduce the cancer, so that some of your other agents can be more effective. Next slide, please. So, when is surgery required? If cancer is detected at an early age, surgical removal is what's recommended, because you get it out of there without allowing it to stay there and relying on other types of modalities to eliminate the pathology. So surgery is recommended when it's small enough where you can get it, but sometimes you can't get it. So that's why the early diagnosis is very important. And we would hope that that if you see something in your mouth or your family's mouth, you say, no, that needs to be looked at. You come in early so we can get an idea what it is, do a biopsy. And then if we can get it out in one procedure, then that's the best thing we can do for you. Next slide, please. Now, as far as surgery itself, they have new in the operating room at Howard and some major other institutions. You have this robotic surgery where you have microscopes and you have robots, and you have other ways to access the lesion that you do it remotely. You're looking at a TV screen while you're doing it. And you're using the remote arms to cut and remove and to incise and treat the pathology. And it is something that's very popular today, and the outcomes are much better as far as management of cancerous lesions in the body because of robotic surgery. Next slide, please. Now, in saying that, once the lesion has spread beyond the jaw and gets to lymph nodes, the surgery to remove the lesion can be drastic and debilitating, where you have to take out part of the jaw, and then you have to determine how you're going to reconstruct it. So that is the issue. Once the tumor becomes so enlarged and it spreads beyond just the oral cavity into the lymph nodes or into the soft tissues beyond the area where it first started, then you have to be more aggressive because you have to get it out. But the question is, once you get it out, what do you have left to rebuild? And that's where Dr. Edler and others will come in to try to rebuild what's been lost. And it's not an easy job because you don't have the kind of support structures nor the health of the tissues. But that's where we are as far as management of lesions that have gotten beyond the primary site and spread to other areas. Next slide, please. And this includes when it spreads down into the oral cavity, we often use flaps. We take flaps from the chest and we rotate flaps up because we have to take out all the tissues that are cancerous, and to cover it up, we do rotational flaps that give the patient closure of the wound, but it also is very debilitating in terms of their appearance. So that you may see some patients like this that have had rotational flaps that have been treated for cancer. Next slide, please. There are opportunities, and Dr. Edler can get this a little bit about reconstruction after you have cancer treatment. You can rebuild it with different types of rotational flaps and fibula and tibia flap, bone grafts and things like that. You can use implants and bone plates. These can be beneficial to restore the continuity of the jaw, as well as give you something to put a prosthesis on. Because once you remove part of the jaw, then the patient needs to still be able to eat and chew. And these things can give the patient something, at least support structures that you can hook a denture on or a prosthesis on that can help them. Next slide, please. In addition to that, when you take out areas of the top of the mouth, the palate, and things like that, you create an oral nasal, oral antral communication. This is where Dr. Edler will come in and speak to you about things that can be used to obturate or close those areas and allow the patient to function. Next slide, please. So in summation, early diagnosis and treatment planning of cancer is critical. With regular visits to your oral healthcare provider can identify what's normal, what's abnormal, and refer you to the appropriate specialist for treatment and management. But the key is you have to come in and be seen. And that is the take-home message from this presentation, is to come in early and be seen early. And with that, I will give Dr. Edler the microphone and the floor to talk about some areas of prosthetic rehabilitation.
Good evening, gentlemen. Can you see my first slide?
Can't see them, Tom.
How about now?
No.
Okay. Where are we? Now. First slide up yet?
Not yet. Present and share screen.
Yeah, I did that actually. I'm not sure why it's not presenting. How about now?
Nope.
Oh,
There we go.
there we go. There we go.
Okay, thank you. Good evening, and thank you very much for this opportunity to share this information with you. I'd like to thank Dr. Smith personally for thinking about me and giving me the opportunity, and also a special thanks to Dr. Raul Bell. I'm sure a number of you probably know him, who was my mentor years ago and started me out on this area of prosthodontics and maxillofacial prosthodontics in particular. As has been so brilliantly covered to this point, the actual diagnosis and treatment modalities are already in place. So now I want to pick up with, you have a diagnosis, you've been staged. Where do we want to go from here? What's next? The disease has been determined, and I can't emphasize enough that the management of head and neck cancer, not just oral, but entire head and neck cancer, is a multidisciplinary approach. We depend on all aspects of specialties, from speech pathologists to radiation oncologists, medical oncologists, dietitians, et cetera, to lend their expertise to help manage these patients. We have enough challenges with men considering prostate issues and prostate cancer, but don't sleep on the oral cancer. We also have to be mindful of that and the implications of oral cancer. We've already talked about the various modalities of treatment, and I would like to reiterate the fact that each modality of treatment has its advantages and its disadvantages. Radiation therapy, radiation does not discriminate. It affects everything in its path. It kills cancer, but it also kills normal, healthy cells. As Dr. Jackson described, chemotherapy, the big thing about chemotherapy is it's systemic. It affects the entire body. So it affects not only cancer cells, but any cells that divide rapidly. So after the surgery is done, or the radiation is done, the chemo is over, do we need to reconstruct? Who do you see, and how is it done? Myself, I am what they call a maxillofacial prosthodontist, and what I do as a specialty is try to reconstruct people after they've had their surgery and or chemo and or radiation. Basically, as a maxillofacial prosthodontist, we try to just restore form and function, make the patient look presentable and have the ability to live as near a normal life as possible. Your dentist, your basic general dentist, may be the first one to see you as a patient, diagnose, and refer you to usually an oral surgeon who may or may not complete your therapy. You may be referred even further to an ENT person or to a larger center for more advanced head and neck surgery. We did already talk about the modalities of treatment, the various surgical approaches. We'll talk about some prosthetic reconstruction, and then the combination of the two. When we're talking about surgery in particular, we also want to be mindful of what areas we're dealing with. Again, prevention is the name of the game, and it's always helpful, if not indicated by necessity, to see your dentist before starting any type of chemotherapy, not just for example, oral cancer, but your wife's breast cancer patients, prostate cancer patients. You should see your dentist before therapy begins. As we all know, there's bacteria in the mouth, and everybody doesn't have the best oral health. And when the chemotherapy drugs kick in, or even if radiation affects the mouth, the body is not able to respond properly, and then we'll have complications associated with chemo. So I highly advise and recommend that anyone, loved ones, friends, colleagues, about to have chemotherapy or head and neck radiation therapy, please see your dentist. Any bad teeth or sites that can become an area of infection during therapy can be addressed prior to the therapy. Some of the reconstructive aspects can be a little more aggressive, and it's not, like we said, just confined to the oral cavity. We have some instances from either skin cancers or other aggressive cancers that not just limited to the mouth, but also to other areas of the head and neck. In this case was an actual case where the orbit had to be exonerated, and then we try to do a prosthetic reconstruction to rehabilitate this individual as best as possible. And that's where we come to, this is just an acrylic prosthesis, does have its drawbacks in terms of the margins, but the idea is to be able for this individual to go back into society. We then take maybe some glasses to mask the margins and try to make them as presentable as possible. Additionally, as a maxillofacial prosthodontist, we try to restore not only eyes, but also ears. If you notice, this gentleman has one ear and a Band-Aid on the top, and this was a basal cell carcinoma. Again, sunlight, fair skin, lost an ear. So we come back and we try to prosthetically rehabilitate this individual with an ear prosthesis. This is a silicone prosthesis. It's used to, it's maintained with glue, actually. And when the patient presents it, we also use magnets, we use implants now. But the problem with implants is oftentimes we're limited because the radiation may have affected the bone. As we noted, radiation affects not only the good cells, the good tissue, but it also affects everything in its path. So in the instance of radiated tissue, implants can sometimes not be used. And then we have a situation where the prosthetic ear. Eyes, ears, and on occasions we have the opportunity to do a nasal prosthesis. Sometimes these are magnetically held, sometimes held by tape, oftentimes by implants if we were able to go into a non-irradiated area, in which case this is a silicone, use some of his hair, hide the margins, place some glasses, stain it, color it, paint it, and hopefully he can be a little presentable to go in the street. Now, when we look back on some of the more aggressive intraoral prostheses, again, you've seen something like this before, a malignant lesion in the palate, but also we look, and it also involves the maxillary sinus. So this tumor has invaded not only the inside the mouth, but also the entire maxillary sinus. And this would be a more aggressive case, which was done with head and neck surgery department. And we started out with a simple denture. And the idea is to start rehabilitating the patient as soon as possible. And the best time to do that is intraoperatively. So by going to the operating room with the surgeon, and the surgeon excises the tumor and the large excisions in order to get clear margins and a nice clear field, then it's time to start the rehabilitation while the patient is still on the table. The tumor is resected, and you're looking at the maxillary sinus in this area, but we take out a pre-made teeth prosthesis and put it in right at the time of surgery. So in a situation like this, the patient already has something to function on. When they awaken, they still have the nasal tube in, which is soon removed because now the patient can chew, swallow, speak. So this is just another modality of treatment, but we also place emphasis not only just the prosthetics. I think we've also had a lot of discussion already on chemotherapy and radiation, so I won't reiterate that too much, but I will say, for example, we do have complications with both of these. They both have their own indications, but they also have their own complications. One of the biggest complications we see with cancer therapy, period, is infection, particularly with, for example, the leukemias. When the white blood cell count is diminished, the patient is not as able to fight off infection. And the other problem is chemotherapy, which diminishes your blood cells. So your platelets become low and bleeding is a problem. So bleeding and infection are common problems associated with chemotherapy. Now, we also have to manage the complications, as Dr. Jackson was saying earlier. We have problems with radiation and chemotherapy that we not intended. We just want to kill the cancer cell. But with radiation therapy, it's generally specific to that site where the patient receives the radiation. It's depending on how much they receive, what type they receive, and how frequently they receive it. But at least for radiation, it's very site specific and it doesn't affect the whole body. Here we see a picture of a cheek. Patient was radiated, and this is the side effect of what we call a radiation mucositis from radiation burning the cheek. Again, radiation mucositis, but it's all located in a specific area that was targeted by the radiation oncologist. One of the side effects also of radiation, particularly when the mouth is radiated, we have a problem with knocking out the salivary glands. So people have quite a problem with dry mouth. And as a consequence of dry mouth, we also end up with what we call radiation caries. So your dentist, again, is very important to manage, hopefully before treatment, but an example of the decay that takes place in the mouth as a result of radiation therapy. And in this instance, where the jawbone has been radiated, it's not as simple and not safe to oftentimes go back in and try to extract teeth in an area that has been radiated. Under those situations and circumstances, run a risk of what we call osteoradial necrosis, where the bone will not heal, and then you wind up losing substantial parts of jawbone because the bone essentially died and became non-vital. And we do have methods of managing that. Hopefully on the front end, we try to manage it. We put people on fluoride, but compliance is our biggest problem. So you have to assess the patient before treatment. Oftentimes a patient with poor oral hygiene, if they don't take care of their teeth and haven't taken care of their teeth up to that diagnosis, it's very often those old habits would change. So a lot of times we actually have to take teeth out to prevent them from having the complications later after radiation therapy or chemotherapy. And as we talked about the mucositis with chemotherapy, it usually affects the entire mouth. So chemotherapy, for whatever reason, when we have a situation with mucositis, what we call it, and it involves the entire, and it's very uncomfortable. The tongue is very sore, taste is lost, food doesn't taste the same. So it's a problem oftentimes managing the complications, just dealing with the treatment of head and neck cancer. But those are the main areas that we strive to manage the complications as well as restore form and function as a prosthodontist. And I thank you for your time and attention.
I want to thank you, Dr. Edler and Dr. Jackson, for this outstanding presentation. It has been, we've covered a lot of material, and I'd like at this time to take just 1 or 2 minutes for a wrap up from each one of us. And I'll start off by saying, basically, there are 3 points that I'd like to make. And the first point is to those out there listening and attending, please pay attention to lumps and bumps, red and white, okay, and anything that doesn't heal. Lumps and bumps, red and white, and anything that doesn't heal. And number 2, make sure your dentist, when you see him, hopefully on an annual basis, does a cancer screen.
Right.
So those are the things that. And my third point is limit your tobacco use. I know cigar smoking is a thing right now, but limit your cigars. Okay, so I'll pass that on for just a quick summation from you, Dr. Edler, if you would care to.
Sure. One thing I would love to reiterate to anyone, because it's so frequent now that we all know people who are going through chemotherapy in particular. Radiation is one thing for head and neck, but we have so many more people, friends and family that go through chemotherapy. Keep in mind, and I'd advise everyone to, if you know a friend that's going to have chemotherapy or scheduled to have chemotherapy, see your dentist first, because there's a lot of discomfort can be managed on the front end, a proactive approach, and oftentimes that's oftentimes overlooked. I see so many people and I hear so much conversation about people who are on chemotherapy and the problems that they're having with their mouth. And a lot of that can be avoided by doing a little preventive maintenance on the front end. It's nothing worse than becoming immunocompromised and you don't have blood cells, white blood cells or platelets, and the oral surgeon can't take the tooth out because of your overall systemic health. These type of things need to be done beforehand, and they're often overlooked. So recommend that chemotherapy is going to be recommended. See your dentist first. Thank you.
Thank you. Dr. Jackson.
And I didn't piggyback on that because at Howard, we're part of the oncology team. So before a patient undergoes any chemotherapy, radiation therapy, they come down for an oral screening or oral screening, so we can determine which teeth are healthy, which ones need to have some type of treatment, which ones need to come out. We want to have that done prior to the actual surgery, the radiation treatment or chemotherapy. So there has to be understanding that one part of the body does affect the other, and we cannot separate things out. We have to be part of a team to manage our patients. So that's the things that we look at as we're not only looking at how we treat the patient, but also insurance coverages and things like that. We've been advocating as part of our political action committee of AMOS to help the dental coverage to follow the coverage for radiation and chemotherapy as surgery on the jaws for head and neck cancer, so the patients can have a quality of life, as Dr. Elliott mentioned, and they can get something, they allow them to chew, allow them to smile, and allow them to exist in society. So there's the ways to go, but once again, the take-home message is to early treatment, early evaluation. And if you notice something that is wrong, have somebody take a look at it. Don't assume that you're just complaining. Just if you feel something not right, have somebody take a look at it. Have one of your oral health care providers take a look at it. And that I think in the long run they can help you.
Okay. There is a question that I have received, and there are two questions. One that I'd like to go to first is, when oral cancer is diagnosed, we've talked about it being a multidisciplined treatment modality. Who leads the case? Who coordinates the care? Is there one specialty or one individual that coordinates it?
I can speak for my institution. We have a tumor board. So once it's diagnosed, the patient will be seen by the ENT surgeon, who normally team. So every patient that is diagnosed, first thing is staging. Once they're staged, as we talked about, and they're given a TNM classification, and all parties come in and recommend what the types of services that will be required. And at that point, they'll go from one to the other, depending on what the sequence is recommended. And that's how the patient is matriculated through Howard Hospital, and how many institutions do it. It's not easy in the private office, but that's how we do it.
Okay, but thank you. There's a question in the comments section from Brother Ray Smith. Does hookah pastime fall under that cigar category? It may not fall under the cigar category, but it is a tobacco. And so, as we said early on, cigarettes, cigars, hookah, snuff, all of those, and anything that is tobacco related has an affinity or can lead to an incidence of oral cancer. Okay. Thank you, Brother Smith, for that question. Okay. I don't see any other questions at this point in time, and we perhaps reached our time limit also. But I just want to take the time to especially thank Drs. Edler and Dr. Jackson for sharing their expertise in this discussion tonight. And I say to you, thank you very much. To our people who are listening, who joined us tonight, I want to thank you for joining us. We hope that you have learned one or two things that you can take with you, and then if you will share that information with others, that oral cancer is for real. Okay, even though it accounts for 3% of the cancers, it is for real, and it does do damage to people and affect their quality of life. So we thank you for joining us tonight, and I would say that all of our presentations can be seen and on Alpha Phi Alpha Sphinx TV, which is YouTube. And so I invite you to go there and see this one and all of our presentations. So with that, thank you for joining us. And I say good night to all.
Thank you.
Thank you.
Good night.